I'm a doctor, but I can't think clearly anymore, so I can't do my job.
Long COVID causes debilitating cognitive issues.
I'm a runner, but now I can't walk 100 feet without getting exhausted.
Long COVID causes crippling fatigue that may last a lifetime.
I've lost friendships because of long COVID. I just don't feel well enough to see people.
People may look outwardly healthy, but they're suffering from a physical disorder that can upend lives.
Everything hurts. I can't even go out and play.
Up to 30% of COVID patients develop long COVID, and right now, there's no cure and little understanding.
I can't focus, I can't think straight, I can't keep a job.
So for those suffering daily, there's just one urgent question.
How long?
How long?
How long?
How long?
Until we solve long COVID. The Solve Long COVID initiative is bringing together patients, researchers, doctors, and drug developers to find answers now. To learn more and see how you can help, go to solvelongcovid.org.
Good afternoon and welcome. I'm Don Rissmiller, a member of the GIC's Board of Directors. We just viewed a public service announcement produced by the Solve Long COVID initiative, which will soon be distributed nationwide, and we are glad to have shared it with this audience. On behalf of the Global Interdependence Center and the Solve Long COVID initiative, welcome to today's executive briefing. As a reminder to our guests, this event is being recorded and the replay will be available through the GIC website. Today's executive briefing is a continuation of a program series designed by the Global Interdependence Center and Solve Long COVID initiative entitled Long COVID, Research, Policy, and Economic Impact. Throughout 2022, GIC and Solve will bring together world-class immunologists, medical experts, policymakers, and economists to explore critical insights into defining, diagnosing, optimizing treatments, and creating healthcare policies for long COVID and analyzing its impact on the US and global labor markets. I would like to extend our sincere thanks to David Kotok, longtime friend and supporter of the GIC. In 2021, David and the Solve Long COVID initiative offered a new gift to the GIC for funding, sponsorship, and logistical support for the Long COVID program series. We thank him for his generosity and dedication to researching and understanding post-infection diseases. At this time, I am pleased to introduce our first speaker, Senator Ed Markey of Massachusetts. He is a consumer champion and national leader on energy, environmental protection, and telecommunications policy. He has a prolific legislative record on major issues across the policy spectrum and a deep commitment to improving the lives of the people of Massachusetts. He is an original co-sponsor of both the Care for Long COVID and Treat Long COVID Acts. Senator Markey will be joining us to discuss current and future long COVID policy priorities. It is my pleasure to welcome you, Senator Markey.
Excuse me, Senator Markey, it looks like you might be on mute. If you could please unmute yourself.
Can you hear me now?
Yes, we can, Senator.
Okay, thank you. So thanks so much for inviting me here today. And thank you to the Global Interdependence Center and Solve ME for the invitation to speak on the issue of long COVID and for your continued partnership and advocacy for long COVID patients. This is my 46th year in the United States Congress. For 36 and a half of those years, I served over on the House side on the committee with jurisdiction over healthcare. And over here in the Senate, I continue to focus on these issues. My wife is actually a retired two-star admiral in the public health service and was Assistant Surgeon General of the United States and is a career public health doctor. So I get the message at home on an ongoing basis that we continue to lose the lessons of the past in terms of infectious diseases moving through our society. And it's gatherings like this that are going to push us forward in a robust and coordinated response to long COVID, bringing together experts on economics and health research. In this series, you've looked at the potential impacts on children, on our workforce, and on where the research is. And I'm very glad to be here to talk about the work that has been done and must be done in Congress to move us forward in better understanding and responding to long COVID. While our national goal is to fight anything that is emerging from the ongoing COVID-19 epidemic, millions of Americans will continue to feel the lingering impacts due to their experiences with long COVID. There are more than 20 million Americans reporting long COVID symptoms. Of that, 7 million are reporting disabling symptoms, which may result in reduced work hours or lost jobs. We all know that long COVID symptoms are as different as they are complicated, from debilitating fatigue and brain fog to increased risk of stroke or heart attack. It can impact your digestive system, your metabolism, and your brain function. And our nation's children are not exempt from this illness. With the growing numbers of people experiencing long COVID, this will have a huge impact on our healthcare system, our care economy, and on our workforce. We need to take on the long-term impacts of COVID as aggressively as we've taken on this virus. So let's think of it this way. If there are about 20,000 new COVID cases each week, that could translate to hundreds of thousands more whose lives are altered in the long term. As frustrating as diagnosing and managing long COVID symptoms are, it's equally frustrating that there are still so much that we just don't know. We've got to do more to define what long COVID really is and how to diagnose it. We need to make sure our resources reflect the new reality, but not the new normal of long COVID. And we need patients to know that what they are experiencing is real. They will be supported. We have their back. We believe them, because patients are not making these symptoms up. They are not exaggerating the impacts, and we can't underestimate how pervasive this illness could become. So more than 2 years ago, I called attention to post-viral diseases and the rise of ME/CFS with COVID-19. And shortly after, Congress appropriated more than $1 billion to research long COVID. The research has made some progress. The National Institutes of Health is looking at the ability to predict, to treat, prevent long COVID in children, adults, and pregnant people. The Centers for Disease Control is looking into the long-term effects of COVID-19 through patient surveys over 18 months. And the VA is conducting studies on symptoms, treatments, and prevention through the establishment of multidisciplinary clinics. So that's important work, but we have to do more. We have to do much more, and we have to move very quickly. The great Jesuit philosopher Teilhard de Chardin is quoted as saying, "Research is the highest form of adoration. Research is medicine's field of dreams, from which we can harvest the findings that will give hope to families." Well, if we care about the patient and we care about treating them, then research is step number one. Federal research should move in lockstep with ensuring that people currently experiencing long COVID and post-viral illnesses have the resources they need, the information they need. Do people with disabilities know their rights to an accommodation in the workplace? Do they know what benefits they might be eligible for? How can we be sure students continue to access their education while battling debilitating fatigue? These are questions that need answers, which is why I am leading an effort with Senators Tim Kaine and Tammy Duckworth to urge the Social Security Administration to improve its guidance on people seeking disability benefits due to long COVID impact. We don't want to look back and ask what more we could have done. And this is why I introduced the Care for Long COVID Act with Senators Duckworth and Kane. This legislation takes a multifaceted approach to a multifaceted problem. First, the bill would direct hundreds of millions of dollars to improve research and education. It would facilitate the continuation of research into the cause, the diagnosis and treatment of long COVID. We have talked about current work that's being done, but these grants will ensure we can keep moving forward and staying on the cutting edge of understanding. This is new. We're in a new frontier on these issues. Second, my legislation would ensure that providers understand what long COVID is. I know many people have gone to doctors who might not believe them or who might not identify a series of symptoms as long COVID, leaving patients feeling frustrated, unheard, and stigmatized, compounding their symptoms. My legislation would make progress to change that. In addition, funding from the bill would help people understand and access disability benefits that might be available to them. Those suffering from long COVID should be able to easily and fairly access disability benefits, period. My Care for Long COVID bill would make sure agencies work together to understand COVID treatment and share data on what treatments and disparities exist. Utilizing this information sharing, we can move forward with a whole of government and a body approach in creating a comprehensive healthcare response. Long COVID is real. For millions of Americans, the long-term impact of COVID-19 has been debilitating, disabling, or caused irreversible damage to their mental and physical health months or even years after their initial infection. This is unacceptable. And the next great challenge of our public health system resulting from this pandemic just has to include a focus on this issue. Progress is not enough without results. Our national recovery from COVID-19 is incomplete without truly understanding and addressing long COVID. It is urgent that we dedicate our attention and resources to this effort, and that is what I am fighting for. Thank you for having me here today. Thank you for everything you are doing to raise awareness on this issue. You are truly doing God's work here on earth. Thank you so much for everything that you're doing on a daily basis.
Senator Markey, thank you so much for your time. We are so grateful you were able to join us today and for you sharing your perspective on this important issue. So grateful. And I just wanted to also offer personal thanks for all of your work in the past on myalgic encephalomyelitis, a precursor to long COVID, which you were on the forefront then, and you continue to be on the forefront now. Thank you so much, sir, for your time.
No, so great to be with you. Thank you so much.
Take care. And now we'll switch over to our next panel. I'm very excited to join me with 4 great speakers. We have first Cynthia Adinig, a board member of Solve ME and a marketing expert turned long COVID patient advocate after becoming sick with COVID-19. We have Oved Amitay, the Solve ME CFS Chief Executive Officer and President, as well as a wealth of background that I won't have time to get into about research and drug development in the pharmaceutical areas. We also have Dr. Nancy Klimas, a name that those of us in the community are very familiar with, one of the leading experts and clinical care providers for post-viral illnesses, including chronic fatigue syndrome, myalgic encephalomyelitis, long COVID, and Gulf War illness. And last but most certainly not least, we have Dr. Susan Levine, who is the former chairwoman of the Chronic Fatigue Syndrome Federal Advisory Committee, and also a practitioner who serves patients in New York with long COVID and ME/CFS as well. Thank you so much to this amazing panel for being here. I'm just going to dive right in. We're here to talk about long COVID policy. So what is the most important, and what are we doing right with long COVID policy currently, and what are we doing wrong? Cynthia, I'll let you take it off from there, and then I'll rotate around.
Thank you so much, Emily. I'm really excited to have Don Beyer and Congressman Dogmeyer, Congressman Bergman back again, because their original legislation included what I see happening, the problem that I'm seeing happening the most right now, which is doctor education. We're still lagging so much in doctor education of long COVID, just the basics. It's causing a backlog in recovery. I'm still fighting all the time to have issues in just getting adequate care for myself and my son. I really think that we should have gotten a hold of that, and it was really important that we pass that legislation sooner rather than later, because it's only going to get worse. We really need more people getting proper care. But I think what we're doing right is now creating a lot more legislation that has a better chance to pass in the House and Senate to really push forward to get what we need, which is money for funding for research and funding for education for doctors.
Thank you, Cynthia. Critical issue. Oved, from your perspective, what are we doing right in long COVID policy, and what can we do better?
Thank you, Emily, and thank you very much for the Congressman for joining us today. I think that the things that we've done right is certainly the allocation of the $1.15 billion to the NIH. To really look at long COVID and understand the pathophysiology and really what's going on, and really have the foundation for additional research. So I think we did that right. This was a significant amount of money for NIH that has now started to really be incorporated into a lot of research programs. I think the part that we can do better is really accelerate the pace of getting into treatments. And I think that probably what we all need to consider is that while COVID-19 itself is a novel coronavirus, but the impact of viruses on people and the long-term implications, we've seen that in the past. In essentially any outbreak that we looked at, there were always a subset of people who really didn't fully recover. So I think we need to incorporate that knowledge, and I'm sure that Dr. Clemens will talk more about how could we do that better. And then I would also add one more thing, which I think we started to, well, we didn't really do it well at all, and this is to, in order to have research be done effectively, we need to have data. And we did not have any data in the U.S. really as to the scope and the magnitude of long COVID.
Yes.
And I think that Congress started to play a bigger role in making sure that agencies like the CDC collect the data, and more importantly, share the data with the public. And so we started to see that recently in May and June for the first time, CDC sharing data about the prevalence of long COVID here in the U.S., and with a very specific focus on disparities, really understanding how long COVID impacts communities of color and other marginalized communities. And we do see a different prevalence in different populations. So I think this is something that we've started to do better. And some of the legislation that we're talking about today will continue to have impact in collecting the right data so that research could really move forward more effectively.
Thank you so much, Oved. I couldn't agree more. That's just absolutely critical issues, especially about disparities that we've been talking about a lot in the long COVID community. Dr. Nancy Klimas, just yesterday, Politico posted an article in the healthcare section entitled, "Doctors are taking it on themselves to figure out long COVID." From your experience as a medical professional in this field who's practicing and seeing patients every day, is that accurate?
Absolutely. I mean, that is, I think, one of the most, I feel like, deja vu all over again, because with MECFS, doctors had to learn how to do this. And I myself have been in the field for nearly 40 years, and it has been an amazing learning curve. And we have learned a lot, and we know what to do that helps. We know, and to some extent, we certainly know what not to do, things that hurt. And I get the feeling with long COVID that the providers are learning through experience, unfortunately, what hurts, and that there's a lot to be gained from the experience of the MECFS community and the providers in that community to at least start on a reasonable playing field where you know that it's pretty easy to put people into a serious relapse if you do the wrong things. And so it's really important right now that the MECFS provider community shares its knowledge with the long COVID providers. I'm also going to say that we just need a lot more providers that know what to do, because there's a whole lot more long COVID patients out there than anyone ever anticipated. And the already underserved population of ME/CFS can't manage the, I mean, my clinic is an example. We have 7 providers down here at Nova Southeastern University in South Florida, and we are working full tilt and have done everything we can to open new spaces and places for people. And there's no way we can care for the number. We anticipate that just in South Florida, there's 700,000 new cases right here. And so that's, you know, way beyond our capacity. So what should we be doing? We're academics. We should be out there training the providers, do the train the trainer thing, right? Train providers on what to do, at least how to get started. And it's kind of neat to hear that Politico already picked up on this tune, because a lot of these clinics that are calling themselves long COVID clinics are really more focused in on pulmonary fibrosis or people that had serious organ system damage, rather than the illness that is more generalized, that is long COVID. So that's one thing. And the other thing I'd say, you know, lessons learned in all these many, many years is money helps. And I'm going to say that this congressional investment in long COVID, I've never seen the NIH act so amazingly quickly to roll out a substantial, significant, important research program that is underway with significant recruitment, more than half the recruitment already accomplished for the recovery program. Very, very impressive. So what that needs to do, just like you were saying, Oved, was how do you move this new knowledge, this basic science knowledge or observation of pathogenesis knowledge rapidly into intervention? And that requires, money and actually a real emphasis on using repurposed drugs that are already proven to be safe, so that we can roll them out really quickly.
That is a great segue into my next question for you all. One of the and this is kind of rapid fire round as we run out of time. But since we are focusing on congressional policy today, what is the one beacon that you think can Congress do that will really change the field of long COVID and address those barriers we've talked about? Cynthia, I'll start with you and we'll go around one more time.
I think what needs to happen is to really look at this as a universal issue. There's no red, there's no blue. COVID does not discriminate, and so we know that every population, whether Republican or Democrat, has long COVID in it and has people and constituents that need access to care so that we can continue to keep our lives going and our economy going. And as soon as we can take it seriously, get all members of Congress to take it seriously, that this is an economical issue that's already showing harms in our economic and our workforce, and it's a constituent issue of all sides, then we really can get some legislation that's already drafted passed, so we can get things going in the right direction for patients.
Fantastic. Thank you, Cynthia. Oved, your thoughts?
Maybe so a couple of things. One is I think Senator Markey talked about the continuation of the pandemic. I think we first of all need to remember that this is not over. And I was just I was reading the some of the efforts to continue making sure the vaccination could be provided through the government support, which I think is incredibly important, because right now we don't really have good tools to diagnose and treat people with long COVID. So one of the best approaches would still be to prevent getting COVID in the first place. And there's now plenty of evidence that the vaccination does reduce the risk for developing not only COVID, but also long COVID. And so the continuation of accessible vaccines, in my mind, is something that Congress need to continue to address, pushing this to become sort of like what we do with the flu is probably still premature. So that's one thing we still need to focus on prevention. The other thing that I think we can learn from early success is Warp Speed project, which was really a public-private enterprise to develop vaccines. And this is probably something that Congress could continue to do, which is to create those kinds of large programs that bring the public sector and the private sector to work together to develop those solutions, both on the access side, as well as really developing treatments and better diagnostic. This is something that I think, as Cynthia said, and Dr. Columbus, this is not something that one clinic or even the NIH can resolve. We need more resources to be poured in. And I think that Congress can create the right incentives for those things to happen. So prevention, but also really bring more resources to deal with the issues that we're facing right now.
Thank you so much, Oved. I think that the Congress is listening because I know there's a lot of really interesting bills that are currently under consideration. Dr. Klimas, from your perspective, and if you'd like to take a few extra minutes, both look at the research side and the clinical care side, what do you think Congress can do to really accelerate progress on this issue?
Well, one thing is this provider education. Don't underestimate the role of the CDC in doing excellent provider education rollouts. They certainly have helped us with the ME/CFS provider education area, and it would be important to remember that kind of thing. The VA is another place that you heard the senators speak about these multidisciplinary programs that are being rolled out, which is really impressive. Veterans might be a particular risk because of this two-hit theory of having a brain injury, whether it's a toxic injury or a traumatic brain injury, or PTSD, anything that messes with the basic biology of the brain, making it more vulnerable to a second hit from a virus. And so there's a real concern that needs to be focused there on veterans' health. And I'm going to say another research moment is how impressed I am with the CDRMP model, which changes the focus of the research every single year based on what happened last year and on funding. And so in the CDRMP, you'll see initiatives that they're written every single year and are integrate the patient advocacy community in the integration panels that decide on the priorities of that particular research funding. And they've been highly effective at rolling out very quick projects that often include clinical trials much quicker than they might otherwise have been able to roll out through more traditional funding mechanisms. So I want to do a shout out to the CDRMP, the way they run that program. It's really extraordinary how quickly they can respond to new knowledge and get it rolled right into a clinical trial within a year's time. And so I think those are really important points. From the patient care point of view, this is a very, very, very vulnerable population. And we're doing a big study for the CDC right now. And when we look at our people who consider themselves recovered, our so-called healthy controls, half of them are not recovered. Half of the people who perceive themselves as having fully recovered actually have symptoms they did not have prior to their COVID infection that they're carrying on for months and years later on. And so there's a bigger problem than we might think with a spectrum of illness that goes from mild to severe, just like you would expect. So I'm afraid that it's here to stay, and it's going to be a great big problem on the medical health scene for decades to come.
Thank you, Dr. Klimas. And for our audience members who might not be familiar with that acronym that Dr. Klimas is using, the CDMRP is the Congressionally Directed Medical Research Program, a funky little research group out of the Department of Defense that is really unique because, as Dr. Klimas said, it updates its priorities every year, and every year Congress directs different directions for funding. So it's very cutting edge. It's one of, I've heard experts refer to the NIH as your regular beat cop on the street if they're just your regular writing tickets, doing your everyday stuff, whereas the CDMRP program, or the Congressionally Directed Medical Research Program, is the SWAT team. They're high impact, high reward. They come in there really fast and then they get out again. So just to give a little bit of background about why that program, Dr. Klimas, I agree with you, should be highlighted because it has done so much so quickly for a lot of different illnesses. With that, I'm afraid we are out of time. So thank you so much, Cynthia, Dr. Klimas, Oved, thank you again for your time. We're switching over to the part of the panel that I'm most excited about, so I hope I don't get too overwhelmed, where we are joined by Congressman Don Beyer and Jack Bergman from Michigan from Virginia and Michigan, respectively. I am so excited to have you both here. It has been an absolute joy to work with both of your teams the last couple of years on this issue, and so I just will get us kicked off with if Congressman Beyer, if you'd like to go first, if you'd just like to say a few words to kick us off, and then Congressman Bergman, we'll jump to you.
That sounds great. Well, thank you very much. Thanks for inviting me and Jack. I'm thrilled to be part of this panel and to listen to my good friend, Senator Markey, and my esteemed colleague, Mr. Bergman. Mr. Bergman and I partnered on the COVID Long Haulers Act. It's an old title. It reflects how much and how little has changed since we introduced it. Senator Markey and I are both Jesuit educated, so I was so impressed when he quoted Father Pierre Teilhard de Chardin, whose famous book, The Phenomenon of Man, lays out the idea that history is linear and progressive, alpha to omega. And we actually see this progress every day in our scientific lives. I was proud when Congress appropriated over $1 billion to NIH research to help address long COVID last December, so December 2020. At that time, it was only Jamie Raskin, Jack Bergman, and I in the House talking about this and needing to pay attention to this post-viral illness. And it was a big victory that we got that basic research money at a scale, but we're still left with lots and lots of unknowns. I'll repeat some of the stuff that you said. CDC mentioned in May that 1 in 5 US adults under 65 who had COVID experienced symptoms that could have been attributable to previous infections. There's an ongoing British national survey that's found about 3% of Britons in July experiencing ongoing symptoms. So the numbers are still really imprecise, but millions of Americans. The GAO estimate in March was 7.7 million to 23 million Americans have developed long COVID. And maybe 1 million people are out of work at any given time due to the condition. But a more recent Brookings report estimated that long COVID could be keeping as many as 4 million people out of the workforce. When labor force participation is one of the most important drivers of economic growth, this is a very big deal. We have almost 11 million jobs advertised and unfilled. How many of these could be filled, those 4 million folks? And this was based on the US Census Bureau's June to July 2022 survey, that the economic burden of lost wages is approaching $200 billion a year. But the full magnitude of the health and economic impacts still unknown, but we know is very, very significant. And we just heard in this last panel how physicians are struggling to understand and be responsible to their patients. Wall Street Journal story today said that long COVID sufferers have a large measurable amount of the spike protein of COVID-19 in their blood up to a year later. Very different from those who had COVID and recovered, where there's none of this spike protein in their blood. And the thought is that this protein is going to create the ongoing immune reaction, which will lead to long COVID symptoms. But we know that some patients are in the third year of their disease already without a solution. So our research is not fast enough or broad enough. Our clinicians still lack awareness. Patients still face uphill battles. I was thankful that the administration recognized long COVID as a disabling condition under the Social Security Disability Insurance last summer, something we've been fighting for. I'm also glad of the attention the administration's paid to long COVID in two recent reports, the National Research Action Plan and the Service and Supports Report. One creates a more specific government-wide national research agenda. One outlines federal services available. But this is not enough. Except day one that we need to help the patient and improve the patient experience. This is why our bill with Mr. Bergman works to address these gaps. Create a patient registry. Learn what treatments and therapies work on who. Perhaps use PCORI, the Patient-Centered Outcome Research Initiative, to address this. And educating the public and clinicians about long COVID so that we can improve diagnosis and health systems response. Well, practically speaking, most Americans have moved on from the COVID pandemic. I was just on a trip to Southeast Asia with Senator Markey, and in Taiwan, Cambodia, Guam, and the Philippines, every person we saw wore a mask. And then we touched down in Honolulu on the way back, and not a single person wore a mask. So our American commitment to freedom is also complicating the public health response. People are treating COVID now like any other cold. Given the availability of vaccines and therapeutics, means most of us aren't going to die. But now that we've shifted away from preventing death, we now have to shift to make sure that the policy response is focused on preventing long COVID. There's no clear evidence yet of who's going to get long COVID, just because you're not hospitalized. Tim Kaine's a great example. Didn't even know he had COVID, but his long COVID has persisted now for more than 2 years. And there are no predictors, at least that we know of yet. It impacts healthy, unhealthy, young, old, millions and millions of Americans. So now is the moment when we concentrate on improving the quality of life for those millions of Americans that continue to suffer physically and mentally. Yet another story I saw just an hour ago about the link between suicide and long COVID. As people get depressed and in despair, when they just don't know when or if they'll ever feel good. So thank you again for inviting me to this event today. I look forward to listening to Congressman Bergman and working with you in any way we can to more effectively address long COVID. So let me yield back, as we say.
Oh my goodness, the congressman yielded me time. I might just have to write that in my diary. I'm excited. Thank you so much, sir. Congressman Bergman, I'd like to turn the floor over to you. You have been a leader in this issue for many years, including, of course, the COVID-19 Long Hauler Act. I'd love to hear your thoughts about why do we need to prioritize long COVID, and why is this issue ballooned to the size and the scope that we are talking about now?
Well, number one, first of all, give me a thumbs up if you can hear me. All right, great. That's one of the first things we do. And when we're, as a Marine pilot, we always had to get a good comm check before we took off on our mission. And we took off on this mission, at least a couple of years ago, but in some cases before COVID, for example, I've been involved with chronic fatigue syndrome for a while prior to COVID even existing. So the point is, in our role as elected representatives, whether you're in the Senate or whether you're in the House, our role is not to be the experts and the scientists. Our role is to ensure that the experts and the scientists are properly funded and directed from a congressional level to ensure that the scientific community, who by and large, I heard someone talk about the police force and the SWAT team. Well, I'll talk about in terms of the military in the Marine Corps, the scientists and the doctors are the Marines of this operation, and they're attacking the battle, the beachhead, if you will, of long-term COVID. And it's up to us to appropriately support, but also to ensure that the intelligence that we gather, that would be the things we learn through our research, are appropriate to next steps. And again, in our case, as members of the House, I've been, Congressman Beyer and I do a lot of things together, and in a lot of different forms, not just this, but our role in Congress is to ensure that you all on the front lines are appropriately funded, but at the same time, the feedback loop that we get from you all says, okay, of the money that was expended or appropriated last time, what have we learned? Do we need to redirect funds to a different, battlefront, if you will? And that is hard for members of Congress to understand. And it is even hard for the bureaucracies, whether it's the NIH, whether it's the DOD, the CDC, whatever it happens to be, to determine that it's time to stop funding an arena and move it because you're seeing results. Don't be hesitant, be direct, and rely then on the communications with Congress to ensure you've got that backup. We're in this, and pun intended here, for the long haul, because so is COVID. And if we don't look at things as Congress from the long haul standpoint of wisely targeting research where we're getting results, and in some cases, those results are a little bit delayed, but we still have to stay the course because we know it's the right thing. So I'm just proud to be with you all today. I listened to, all of the remarks, starting with Senator Markey, and there's a lot of stuff going on both the north and south side of the Capitol and those office buildings to get this project moved forward. But thank you all for your time.
Thank you so much, Congressman Beyer. I'll turn back to you. So one of the questions that that we've been talking about, we've talked about myalgic encephalomyelitis a little bit, or chronic fatigue syndrome, ME/CFS. So and a lot of the times we hear that it was not a new phenomenon, that we knew that there were post-viral illnesses before the pandemic, and we kind of saw this wave cresting before it hit us. What would you say your experience with post-infection illnesses in the past? How did that help inform your work on policy moving forward in the future with long COVID?
I think the fact that there was an existing community talking about ME/CFS really helped us, at least a handful of us, be aware that long COVID was a real possibility. We've seen, well, one of the parallels was with Lyme disease, which for years, people that got Lyme disease were told that it was in their head, or it would just go away, or they were under stress. And it took a long time before even the medical community came around to realizing this was real, it could be diagnosed, and we need to be looking for ways to help. And with ME/CFS, too many friends over the years have struggled with it. People with, extraordinary work ethics and good, sound mental health who, you just couldn't blame it on something else. Other than this long-term viral impact. So I think, in a way that will probably never be recognized or honored, your long work has helped accelerate our attention to long COVID. And as we make progress on the long COVID, I hope at the same time, the insights from long COVID affecting 70 to 23 million people will also redound back to people suffering from ME.
Absolutely, couldn't agree more. Thank you, sir. Congressman Bergman, same question. You already mentioned that your work with chronic fatigue syndrome helped inform your interest in long COVID. How do you see that that previous work being connected to your current work on long COVID?
Well, I think it's almost like everything. The question, I think Congressman Beyer mentioned, he didn't mention a question, he quoted, and I didn't write the Jesuit philosopher's name down, but history is linear and progressive. The point I would suggest to you is, yes, but there are cycles within the linear history. And that's where, when you're doing research, you have to understand if you're seeing something that is cyclical, that all of a sudden relates to something before. We know viruses mutate. We know that nature, that's what nature does. In some cases it's good, in some cases it's not so good. But we have to understand, I believe, the coordination between short-term efforts, long-term results, but in a variable environment where, again, getting back to the scientific part, the accuracy of records, the accumulation, and therefore I guess what I would say, the validation of all the data as it supports what we already know, but more importantly, what it suggests that we may not already know, and therefore direct our future efforts. We have to be nimble. We have to be aware of change. And as in the case of, as I was told in science in high school, don't be too sure of your results, but be very sure of your methods to understand the variability of results.
Fanta, I couldn't agree more. That's so important when you talk about the importance of data. And we were talking earlier about how we're missing a little bit of data. That data has been slow coming. And so perhaps that can be our final question, because I know we're at the top, closing in on the top of the hour. So I would love to put to both of you, Congressman Beyer and Congressman Bergman, what do you see the value of research in this space, and how do you think we can fully fund research in the future? What are the best things that we as a community can do to bang the drum of research funding in this area?
Let me defer to the general. I got to go first the last time. So.
I've got one. Yeah, and thanks, Don. I've got one word: share. Too many times, and I've seen this in my decades within the Department of Defense, and it's in any agency in the federal government as well as other entities that allow it to happen is the creation of stovepipes within an organization that people can be sitting in labs right next door to one another and not have a clue what the other one is doing. The sooner we, at all the levels, different bureaucracies, different entities, start sharing the data and the information. We're not talking classified information here. We are talking data that will benefit and open up potentially the eyes and the avenues for researchers in a different department. That's where I believe at the governmental level, at the bureaucracy level, we can make the greatest advances in the sharing of the information and value for the dollar that's appropriated.
I hope from your mouth to many, many ears, I hope that many folks hear that and will continue to share, because I think that is a critical part of this infrastructure that we're working on together. Congressman Beyer?
I just want to say, anytime I get to share a Zoom platform with a 3-star Marine general, I'm thrilled. And Jack is a wonderful guy. By the way, that Jesuit philosopher was also a geologist, which helped. And by the way, I have made the leap of faith that history is linear, but I might be wrong. It certainly is uneven. We know that. Just have to look at World War II or things like that. But we have to hope that overall it's upward bound. And that takes me back to this wonderful book called on the calamitous 14th century by Barbara Tuchman, who argues that mankind, our biology, and the world is basically the same 700 years ago as it is right now. And the lifespan was 1920 during the Great Plague, and they lived on dirt floors, all that. And the only difference is knowledge between then and today. So everything that we invest in knowledge, in training, in education, and in research, it redounds to our benefits. You know, Jack and I both know that when you go to NIH and the National Science Foundation, they'll say the percentage of excellent projects that they can fund continues to shrink because there just aren't enough dollars. Even if dollars are the same, there aren't enough dollars for the incredible amount of good ideas out there that need to be explored. And so what our job is to make sure that we wisely, in a cost-effective manner, invest in that research. And I think we'll do that together.
Congressman Beyer, Congressman Bergman, thank you so much for the time. That does bring us to the top of the hour. I'm going to go a little bit over. I hope you don't mind. I hope your schedule's allowed. I have one question from the community that I really did want to ask. Somebody asked specifically about low-income and communities and overwhelmed clinics. And I know we've talked a lot about research, which has been a critical first step and a critical first focus on this area. But really quickly, if you could touch on clinical care, especially for the folks who are uninsured, what's the next steps for long COVID policy that looks at that population?
I don't know that we can. Go ahead, Jack, please.
No, I was just going to say that when you look at community-based anything, the federal government is really not your first line of defense or offense to make things better. Federal government in coordination with state efforts, because what we might deem appropriate and best results here in Michigan, given our 4-season climate and the density of neighborhoods, the state solutions where they're already set up in community care and take it out into veterans when we did the Mission Act and care in the community. It's the leveraging of the already existing agencies within the local communities to prioritize. And I think the federal government is the best partner when we listen to the states, because different states could have different needs and also different solutions. You almost create a competitive environment where it's kind of leapfrogging of positive results. Somebody tries something in Virginia and some other state says, wow, that could work here. Or somebody tries something in Florida or Texas, but we go, that method of delivery won't work here because it's 20 below zero and we got 2 feet of snow on the ground in northern Michigan and we can't get our people to the clinics. Okay, it's a difference. I think the balance of state and federal coordination here is our best way forward in the short term. Sorry for interrupting, Don.
It's okay. You know, Jack, by the way, is a Uper.
Yes, I am.
Upper Peninsula is very cool, and I agree with it. I was reading a long essay this morning about the declining lifespan in Americans, and not surprisingly, the greatest decrease was among American Indians. And then you looked at the various levels, and the lowest increases among Asian Americans, that it very much just tied back to income. And because income is also related to diabetes and to malnutrition and to many other things. So finding ways to get stronger economic growth will help. But then overall, we still, in some bipartisan way as best we can, need to address the 28 million Americans who didn't have health insurance for even one day last year. And that's with Medicaid expansion and the like. So we still have a lot more work to do to make sure that all the Americans get the health care they need.
Fantastic. That was a big question, and thank you both for answering it so quickly, because I know I threw it at you at the end. But thank you so much for your time. This has been an absolute privilege and an absolute honor to moderate you both on this very important issue. Thank you so much, Congressman Beyer. Thank you so much, Congressman Bergman, for your leadership and your being champions on this critical issue. I hope that your colleagues follow you and your leadership and your vision on this critical issue. Thank you so much. With that, I'll go ahead and wrap up our panel today. It has been an absolute joy to have you all. Just a reminder, this has been a presentation of the Global Interdependence Center and the Solve ME-CFS Initiative, the Solve Long COVID Initiative, partnered together for this year-long series. Please keep in touch with us, as we have 2 more coming up for the end of the year, that we will be in touch with you coming up on our next panels for the rest of the series. In the meantime, thank you to our panelists, Cynthia Adinig, Oved Amitay, Dr. Nancy Klimas, and thank you again to our partners. Especially I want to give a shout out to Colleen and Siona at the GIC. Thank you for making this all possible. You all are legends. Have a wonderful rest of your day. I hope you enjoy this. And if you'd like to see a recording of this event, you can see it at the GIC, and that's interdependence.org website, or on the Solve ME-CFS YouTube channel, which is solveme.org or youtube.com/solveme. Thank you so much for your time. Have a wonderful rest of your day. Take care, everyone. Be safe out there.